So it's my pleasure to introduce today's fifth and final session. We're grateful to be joined by Drs. Lauren Lobaugh, John Wenzel, and Reggie Fuller. Dr. Lauren Lobaugh is a pediatric anesthesiologist at Texas Children's Hospital in Houston, Texas. She serves as the Director of Safety for Anesthesia Services and co-chair of her department's Quality Improvement Committee. She's the course director of 2 quality improvement electives at Baylor College of Medicine. Nationally, she serves as a member of Society of Pediatric Anesthesia's Quality Improvement and Patient Safety Committee, Wake Up Safe, the American Academy of Pediatrics Council on Quality Improvement and Patient Safety, and the ASA's Committee for Patient Safety and Education. She will be speaking today on understanding human factors in perioperative medication errors and how to build resilience through safety nets. Please join me in welcoming Dr. Lobaugh.
Hello, everyone. Thank you for that warm welcome. As he said, I'm Lauren Lobaugh, and I am an anesthesiologist in Houston at Texas Children's. But I also am a mom to 2 little boys that are 6 and 4, named Wyatt and Everett, and I'm a wife to my husband, who's in the back, of 12 years, who is in the Navy. And I say that, you'll get to some of that points in a minute. These are my disclosures. I'm an educational consultant for Omnicell as well as ISMP. These are my objectives for today. I want to talk about the impact of medication errors on patients and families, understanding the incidence of medication errors in healthcare in general, the role of human factors in those errors, and then opportunities to build safety nets. So I describe myself, and I've said that because I am a human, and I have a life outside of being an anesthesiologist that I've built that affects my daily life, but it also makes me human. This is Martin Bromley, and Martin Bromley is an experienced pilot whose wife, Elaine, died from a medical error in the UK. That error was fraught with many factors that contributed to her death. Ultimately, it was a could not intubate situation, and the people in the room had the experience and the knowledge to prevent that error from happening, but human factors involved in that decision-making or their reaction contributed to her death. And because of that, Martin created the Clinical Human Factors Group in the UK, where he applied those concepts to the healthcare community, hoping to build a structure or a way to prevent errors from happening in the future. So, like Martin Bromley, I like to say, so that others may learn and even more may live. I am a human, and I've had 2 medication errors in my experience that have weighed heavily on me. Fortunately for me, those medication errors didn't lead to death or significant patient harm, but they really shook my core as an anesthesiologist that I could make those errors so easily in my day-to-day with the experience and knowledge and training. How did I let that happen? And I want you to think about those errors and how significant they can happen. These pictures are pictures of people who have died from medication errors in recent years. The young baby in the top is Kaya Zotner, who died from a medication error in the ICU when she received a 10-fold overdose of calcium. The young woman below her is Myra Cabrera, who was a 30-year-old mother who died from a heart attack 1 hour after giving birth when a bag of bupivacaine was administered IV instead of saline. At the top in the middle is Loretta McPherson, who's a 65-year-old woman who was given rocuronium in the ED instead of phosphatidone, suffered a cardiac arrest, brain damage, and ultimately died. In the bottom middle is Charlene Murphy, who may ring a bell. She's the 75-year-old woman who was given vecuronium instead of Versed in the historical case that caused Redondavat to be convicted of criminal negligence. It was a landmark case for our field. The last picture on the left-hand side is Kimberly Hyatt. Kimberly Hyatt is a victim in itself because she's a nurse who committed the error for Kaya Zotner and ultimately committed suicide. So medical error is reported to be the third leading cause of death in the US. There's speculation on what the incidence actually is. Some people say it can be 44,000, some say roughly 100,000 a year, but it's still significant. But I argue, what does that matter? If it's a jumbo jet falling out of the sky every day, would it matter? If you are the one person it affects, whether you're the provider or the family, it matters to that one person. And the sad thing is, most of these errors are deemed preventable. Many of you will have seen this already in your learning experiences. This is James Reason's Swiss cheese model for error. And this came out in 1990, and it showed that there are so many things that contribute to an error. There's not just the act itself, but it's not only the active failures, but also the latent failures that contribute to error. And when you look at safety events, there's unintentional error, there's near miss, and there's violation. Really, my focus is on the unintentional errors, the latent failures and active failures that contribute to error events. This is a breakdown for understanding. You have active errors and latent errors. Latent errors are what's built into a system. This isn't the doers that contribute the actual error, but things like management, things like administration and equipment, things that are beyond the control of the frontline providers. And then there's active errors. There's errors in planning, which is mistakes. It can be you apply the wrong rule when you're making out your plan, or it could be knowledge-based. It's you don't really understand the dose that you're giving, and you give the dose based on what you think you know, but you have a gap in your judgment. And then there's errors of execution, and that slips and lapses that could be contributed to fatigue, distractions, environment that you live in the OR. When we look at what we know about errors, this is a tiered approach. There's the external environment that contributes to the error, and that again is lots of things outside your control, from policies to public awareness, government initiatives, technology. Those aren't really what affects us or our decision making, but it does contribute to those errors occurring, and that's considered fifth tier. There's management decisions, resource availability. If I ask the audience how many people have staffing shortages or a lack of support right now in their ORs, I would assume that every one of you would raise your hand. There's the physical environment. So many times you're in a dark OR with that one little light that you're trying to draw up meds out of your drawer or your pack or your kit, whatever your OR has, and the environment is not ideal, or the environment is frozen. Believe it or not, as anesthesiologists, I think that contributes. If you're so cold that you can't focus on what you're doing, it affects your ability to make good decisions. There's also the human system interface, the devices that we use. There's the controls and displays, the audio. If you've all worked in a cardiac OR, I think the last speaker said he was a CV anesthesiologist. How many times do you turn off the audio on your monitors because that's the culture in a CV OR? There's the nature of the work, the complexity of the workflow. You may be in a group that works really high production. You're doing, in my world, that would be in our outpatient areas where we're doing 14 TNAs or 14 ENT cases, really high volume. You're putting those kids through in a fast pace. And then the final tier, the first tier, which I'll talk about, is the individual factors. And this is the individual performance. It's combines your attentiveness, your sensory to your physical awareness, your experience, your cultural competencies, your motivation. And all these things, as you can see on the pictures, have gone from a blunt end to a sharp end. The sharp end, you in this audience are the sharp end. You are the ones that contribute to the active errors, but the latent conditions also affect your daily work. So I'm going to get into human factors that contribute to that error. This, I think, speaks to me because how many times did gas stations have people drive off with a gasoline pump still connected before they made a change? So I didn't know this until I started looking into safety world and culture. Is there's actually a break-off connection that makes it so that you don't destroy the entire gas station pump when you do this, because believe it or not, it happens quite frequently. But we know these things to be true. We are fallible. Human error cannot be eliminated. Team performance deteriorates in high-pressure situations. Human factors engineering is evidence-based scientific discipline which aims to make it easier for workers to do the right thing. Systemic and sustained implementation of these factors has the potential to reduce the need to rely on exceptional human behavior to improve the safety of patients and well-being of staff. So I'm gonna ask you guys, it's 2 o'clock or 2:20, if you could please stand up. Your postprandial, I know, we gotta shake it out. Okay, so this is called the Stroop test. I want you guys to name from left to right, row by row, the colors, as quickly as you can. Now do it again. Keep going, you gotta go, it's an emergency. The patient's heart rate is dropping. Do we need to call a code? Are you paying attention? Are you drawing up that epinephrine? So this goes to show you, this is stressful, and no one's dying right now. My colleagues at ISMP have identified the human error probabilities in some of their work, and it goes from very low rate, error in a routine operation is 1%. It's not nothing. Selecting an ambiguously labeled controlled package, 5%. Complex tasks requiring high comprehension and skill, 15% error rate. Task involving high stress level, 30% error rate. And ultimately, unfamiliar tasks performed at speed or no idea of consequences, 50%. How many times have you yourself, and I'm sure there are very experienced, competent anesthesiologists in this room, been put in that scenario? We are human. This is a curve that will show you as stress goes up, your performance would deteriorate. It's a known factor. And I would argue that almost every day, if not every week, you are put in a high stress environment where you go from the zone of flow, where you're like, this is normal for me, to the zone of freeze. Hopefully, you find yourself in a practice that doesn't throw these stressors, but that's the whole thing about anesthesia. I think when I was younger, people used to say to me, anesthesia is 80% boredom and 20% excitement, right? Most of the time, our patients do what we expect or have a routine operation, but what happens when they don't? I like to use this picture because I'm a gardener and I love terrariums, but the operating room is this microsystem, somewhat self-contained within a larger hospital system. And a well-known expression in patient safety is each system is perfectly designed to achieve the results that it gets. Think about applying that to your own hospital system. Are there areas of opportunity for improvement that you can identify right off the bat? I look at this picture and I think this is what I frequently find myself doing in my world. As a pediatric anesthesiologist, I'm a board runner. I'm also the director of safety. And ultimately, I'm a clinical provider. So I'm in the OR, taking care of sick kids, answering phone calls from the PACU, answering calls about somebody else's emergency, someone else's policy problem while I'm distracted. Errors can happen. That's because I'm human. As I said, I'm a human. I'm a mom. I'm a wife. If my brother in his job makes a mistake, his errors might not be as deadly as mine. So I look back at the diagram I showed you earlier of reasoned Swiss cheese. How do you think we'll fill these holes in the Swiss cheese? Think of ways that you can apply this to your own systems, your own practice and environment. For me, you have to clearly target the human factors that lead to errors. I like to say, I can't get smarter as an anesthesiologist, and that's not arrogant or that's not making little of what my own knowledge set is, but each one of you has gone to school and trained and studied afterwards. I honestly believe we can't use the phrase of getting smarter or learning more. You have peaked in some respect, so it's time to make the system around you smarter. So it's important for me to try to lean into design and barriers, mitigations, more than education training. In my own group, as a young attending, I've said this many times to my colleagues, we honestly cannot say that we're gonna educate a provider or train them one more time. How many times do you have errors and in your M&Ms or your discussions of adverse events, you say, well, we'll educate that person. You have to get to a point where you decide that we have to build in systems that make it safer for us so that we are stronger as a field to provide better quality of care. I was at APSF last week, the Anesthesia Patient Safety Foundation, presenting some of my work with my colleagues in pharmacy, and I asked that audience to describe the relationship between pharmacy and anesthesia in their hospitals. I'll ask you guys to think of the same things. I honestly thought this was more positive than I was gonna get. Most people, when I talk to them, say pharmacy lives in a fantasy land, or pharmacy has no idea what we do. And recently at my hospital, we had an RCA where there was a medication error around a shortage. It was a ketamine shortage. And instead of the anesthesia team being solely responsible for the ketamine preparation, we had to have the pharmacy prepare a med. And it led to a 10-fold overdose in oral ketamine given. And when we talked about that event, we realized there are so many factors that lead to miscommunication. In fact, when you look at patient safety and quality improvement, everyone says communication is the #1 breakdown. So at Texas Children's, we looked at saying, we've got to do better. And we need to start with our relationship with pharmacy, which honestly can be very contentious. It can be very frustrating. And I like to tell my pharmacy partners, you guys think that work is imagined and that's how it happens, but that's not how it is. In talking with some of the industry partners at APSF and some of the other work that I've done, Omnicell, as I mentioned, I asked these people, how many of you have spent a day in an OR? Not one of them raised a hand. And I think that that is so profound, because until you live the life that all of us in this room live, with the production pressures and the shortages and the workarounds and how you're trying to make things work, you have no understanding to how to make it better. And so we formed a partnership. We call it the Perioperative Medication Stewardship Committee, and we meet once a month. And that sounds very basic, but it's amazing when you sit in a room and you learn the names of the people in pharmacy and you build a relationship and you share with them, this medication happened, an error happened in our OR. And they're like shocked. How could that happen? And then you have a way to brainstorm and work through that, because honestly, to me, pharmacy has a lot of power. They have buying power. They can change drugs for you. They can bring technology in your OR. But if you don't have a good relationship, you don't know where to start. And so one of the things that APSF and ISMP highly recommend is the standardization of your OR setting. So for me, there are a couple different areas where you can target that. The first is in drugs. So if you look up medication errors, there are a few medication errors that I think should never happen. If you're in a pediatric or adult OR, how many of you guys have the high concentration phenylephrine 10 milligrams in your sets? So for you guys in an adult world, I think that's still a risk. But in a pediatric OR, that drug should not exist. There is no way that I need that drug. So one of the first things for us is that should be eliminated out of our drug set. The other thing is, which is a harder thing to change, is the standardization of colors. Coming from ASAP last week, we met with some of the pharmaceutical companies, and it's so fascinating to hear them talk about all the things that go into the coloring of the plastic cap, the metal coating, the plunger. It's a really complicated thing, but still, I would, if I had my dream world, I would choose a color selection. But there are some people that argue the complete opposite, that it all needs to be black and white, there shouldn't be colors. And so it's interesting to see people's stances on that. But regardless, there are low-hanging fruit in standardization in the OR in terms of drugs. Look-alike drugs should be separated. There's no world where this diphenhydramine should ever be next to that phenylephrine, because you are human. And in a dark OR, when a patient is hypotensive, you're going to grab the wrong thing. Or if the patient's having an allergic reaction, you'll grab the phenylephrine and not the Benadryl. The other thing is standardization of your work environment. So Elliot Grigg and his colleagues in Seattle have this standardized worktop that goes on top of their anesthesia workstation. And they've found that they really lean into this worktop because no matter what, whoever comes in the room, you know where drugs are. In my own group, we have 120 pediatric anesthesiologists in our group, and in the general division that I work in, there are, it's probably 40 people that I interact with on a daily basis. And I can't tell you how many people, the diversity and cleanliness of your OR workstation. There are some people in my group that I know I'm going to walk in and there's going to be vials that are half empty and there's syringes everywhere and I have no idea what's going on with their organization. And then there's the other extreme that are extremely organized and everything's laid out. But what happens when you go give that person that's not as organized lunch? And you're giving them lunch because it's 1 p.m. and they're stressed and you're stressed because it's 1 p.m. and you haven't given them lunch, and you don't pay attention and you grab the ephedrine instead of the flush because it's made with a flush syringe and it's not clearly labeled. This worktop gives you the opportunity to have a kind of knowledge, a roadmap of where things should be. The last is route specific. So how many of you guys have heard of Interfit or Nerfit? A few people. So there is a product available that is route specific. So my hospital has adopted the Interfit, which is the bottom purple, which basically is a specific type of device for enteral feeds, because there are a number of errors where people inadvertently give enteral feeds through IV access. I've never heard of it through neuraxial, but I wouldn't put it past someone. The top is much less common. I think it's harder for people to buy in because of the cost, but it's called Nerfit, and it's basically, it makes it so that when you drop medications with a specific type of syringe and specific type of catheter, you cannot give an IV intended med through a neuraxial route. In APSF last week, we talked about there are now, and I may be wrong in the number, but at least 9 deaths related to TXA being given through neuraxial access. To me, that's unacceptable. And as a group, as a body, as a hospital system, whatever group you want to look at, but as anesthesiologists, we need to do better. And it's not that the individual anesthesiologist was bad, it's that they were set up for failure because they are human, and when you dig in an open matrix drawer and the bupivacaine is next to the TXA and they just look the same and you're hurried and you're rushed because you're 30 minutes behind and the orthopedic surgeon is barking at you of why it took so long to do this morbidly obese neuraxial technique, you're rushed. So these are all opportunities for standardization. The other thing at Texas Children's that we have really tried to lean into is technology. But it's interesting because we're difficult as anesthesiologists. I would say everyone in this room is very content in how they practice. They don't want extra steps, and they, me included, you don't want extra steps. You want to do what you have done for years and you know it works. And so when I come in and I say, well, I want us to do the color-coded labels, the Codonics or whatever vendor you have for color-coded labels, that is sometimes met with serious resistance. At Texas Children's right now, we are doing the wave scanner, and we're piloting it because so many of my colleagues argue, why do I need barcoding? I don't need to do that. That takes time. What's that going to save? Well, recently we had a medication error where someone grabbed succinylcholine out of a pre-filled syringe instead of pre-filled ketamine, and the patient became apneic. Now, luckily, you're in an anesthetic environment in an operating room where that can be addressed immediately if a patient desaturates, and you can bag them up and you can intubate them because that's our wheelhouse. But that doesn't mean that the error should happen. And you should have caught that when you swipe that syringe under a wave scanner, like you can see in this picture easily, and it will read out that medication to act as a safety check, because odds are most of the people in this room have no safety checks in place because we're anesthesiologists and we're different. We were trained differently. But does that mean we're better? Does that mean we're smarter than perhaps our nursing colleagues? An overwhelming majority of hospitals now have automated dispensing cabinets for nursing, but less than half of the perioperative environments have automated dispensing cabinets for anesthesia providers or anesthesia teams. And I really struggle to believe that we're safer. Yes, we have a different knowledge set. Yes, we can do the ordering and the preparing, but that doesn't mean that we're not human and have the potential to make errors. In fact, at Texas Children's want to go one step further, and I want this robot that you see on the left to make all of our medications, or the top 20 in our OR, and I want to put them in locked bins. And that seems like a stretch for a lot of people, but if you have to physically type in the name of the drug that you want to give it, it creates a safety check. And there shouldn't be overrides, because that's how you lead to errors. Now, some people say, well, I need the meds that I need when I need it, and I don't feel comfortable not having epi and phenylephrine and Sux on my worktop and propofol. And that may be true. But then we need to work with our industry partners to build templates. It's like you go to Apple and you see the world and the technology that Apple has, and why can't we have that in our OR? There should be a template that you can put down on your work table, and when you lift up that propofol, it reads it aloud to you and recognizes it in your electronic record. These are my resources, and I thank you all. Thank you.
All right, thank you so much, Dr. Lobaugh, for that excellent presentation. Our next speaker is Dr. John Wenzel. Dr. John Wenzel grew up in New Jersey before moving to Philadelphia, earning his bachelor's degree from Villanova University and his medical degree from Drexel University College of Medicine. Completed his residency in anesthesiology and fellowship in regional anesthesia acute pain at Thomas Jefferson University, where he continued his faculty and is currently a clinical associate professor. His specialty areas of interest include orthopedic, regional anesthesia, obstetric anesthesia, operating room, clinical management. He will be speaking on GLP-1 agonist and anesthesiologist. Please join me in welcoming Dr. Wenzel.
All right. Hi, everybody. It's great to be here. I'm John from Philadelphia. Dr. Lobaugh, thank you for a great talk. Piggybacking on medication errors, we're going to be talking a little bit about risk reduction and risk mitigation with a very big hot topic that I'm sure no one here is a stranger to, GLP-1 agonists and the anesthesiologists, and how do we manage them? No disclosures to report, and I will be using brand names just for informational purposes in addition to generics. So our objectives, we're going to review some of the indications for and pharmacology of the GLP-1 agonists, discuss some of the implications of GLP-1 therapy on perioperative anesthetic management, and then some current recommendations and strategies for elective and unplanned surgery. All right, so what are the GLP-1 agonists? So GLP-1 RAs, receptor agonists, are glucagon-like peptide. This is a gut-derived incretin hormone that stimulates insulin secretion from pancreatic beta cells, reduces glucagon secretion from alpha cells, inhibits gastric emptying and reduces appetite, suppresses gastric and duodenal peristalsis by vagal effects. And though receptors are abundant in the pancreas, they're also found throughout the body. Interestingly, the half-life of the native endogenous hormone is 1 to 2 minutes. Of course, it is significantly longer for the commercially available drugs, and that has implications on both research and management as well. So just some areas for mechanism of action. As you can see, pancreas, a big ticket item, but also liver, kidneys, bone, stomach, heart, brain. And so some of these are good side effects. There's a lot of protective benefits that people are seeing. Some of them are more the ancillary reasons that it works for weight loss and whatnot. So in the brain, increase in satiety, but also maybe some decreased stroke risk. The pancreas, of course. The heart is an interesting one, and there may be some cardioprotective effects that I'll touch on briefly. So these drugs first hit the market in 2005 for diabetes management, very first approved for obesity in 2014 after they saw that patients started on these agents were losing a significant amount of weight. Ozempic was first approved in 2017. These are mostly injectable drugs, although there is one oral preparation of semaglutide. And the overall effects you're going to see are exactly what you would expect to see in diabetes management. Decreased blood sugar, reduced A1C, effectively reducing insulin requirements and lowering blood glucose, but also there's a low risk of hypoglycemia, so there's some attractiveness there compared to insulin. There is some possible cardioprotection, like I mentioned. This is probably related to both overall risk factor reduction, such as blood pressure control, decreased BMI, improvement in cholesterol profile, improved kidney glomerular filtration, as well as some direct stimulation on cardiac myocytes, leading to better endothelial function and microvascular perfusion. In one cohort study on patients considered high risk, they found a 28% reduction in major adverse cardiac events. Weight loss, of course, being the big ticket reason that we're seeing an explosion of these drugs in practice. We've all been taking care of patients on some of these agents for years and years. Why is it getting so much attention now? Is because the prescriptions have exploded. So first FDA approval was in 2021 for weight loss indications based either solely on BMI or BMI plus presence of comorbidities. And the primary reason for this is thought to be the delayed gastric emptying and central appetite suppression. But just for some context, between 2020 and 2022, prescriptions saw a 300% increase, with over 9 million prescriptions written in the last 4 months of 2022 alone. So for weight loss, again, increased satiety, reduced oral intake, caloric deficit, folks losing weight. This can complement lifestyle modifications that might include other behavioral programs or surgery. And these two trials found significant sustained weight loss, especially with a dual action. Tirzepatide not only works by GLP-1, but also by gastric inhibitory peptide. So here's some of the current agents on the market that I'm sure most of us are familiar with different branding for the indication, whether it's diabetes or weight loss. So we have Ozempic, Mounjaro, Victoza for the more diabetic indications, and then Wegovy, Zepbound, currently big ones for weight loss. And these are three of the drugs: semaglutide, tirzepatide, and liraglutide. So some of the side effects, which gets into what is the realm of impact on anesthesia practice. So the most common side effects are the GI ones, being nausea, vomiting, and diarrhea. Again, the delayed gastric emptying leading to reduced appetite and early satiety, the main mechanism for weight loss, and then possible cholelithiasis or pancreatitis. But nausea, vomiting, diarrhea really being the big ones. Lower incidence, but some considerations are for hypersensitivity, acute kidney injury, and caution regarding medullary carcinoma of the thyroid, although that could be a whole other talk by itself because I believe that was done in mostly rat models, which may not translate as much to human patients. So I'm sure almost everyone in this room that practices clinically has been in this exact scenario. You walk into the holding area, we've left beautiful Palm Springs, we're back at work next week, and your first patient's a 42-year-old female, no significant past medical history, but scheduled for a laparoscopic exploration for a rapidly growing ovarian lesion. By chart review, you happen to note a 30-pound weight loss in the last 9 months. Now, you probably already have questions you want to be asking. You're already thinking about what's going to be on your exam, already some concerns, comments. So we do a little bit of digging, and the patient discloses she started Wegovy 9 months ago for weight loss. This was prescribed by an online telehealth service, so it doesn't show up as one of her listed medications in EMR. And her last dose was taken 3 days ago. So what are you going to do? How is this going to impact your plan? There's a few considerations here. This is a scheduled elective surgery, but her weight loss, she's taken a weight loss drug, but she also has a rapidly growing lesion. She doesn't have a tissue diagnosis yet. We don't really want to put this surgery off, but what are we going to do for the right thing to mitigate risk? And we'll come back to this patient in a little while. So again, you probably already have some thoughts about, whether you've seen this scenario before, or what your institution's overall recommendations are, but we could always throw some different information your way. What if I tell you this is an elective knee arthroplasty, not the laparoscopic exploration? What if I tell you this is for an incarcerated hernia, or that you want to do gastric ultrasound but it's not available? What if the patient's also diabetic or on chronic opiate therapy? Or what if it wasn't held for 3 days? What if it was held for 6 days? And this is where it really gets into the weeds, that there can be a lot of difference of opinion in how to manage these patients. So where we're going with this is NPO status. What is the patient's aspiration risk is going to be the big ticket item here. So is the patient truly NPO? So here's just a list of some of the most common drugs and how they're administered. And as you can see, some are indicated only for diabetes management, some for obesity also, and they all have a slightly different half-life. Semaglutide is currently the most commonly prescribed by far and away, Ozempic and Wegovy, which does have an oral preparation, which is Rybelsus, but the half-life of these drugs is very long, 6 to 7 days, about a week. Again, very different from the endogenous hormone, which is about 1 to 2 minutes. And of note, the doses tend to be higher for obesity than for glycemic control. So we know that there's delayed gastric emptying. How long does that last for, and how significant is it? So tachyphylaxis to the gastric emptying component has been a big ticket of not only research, but also some disagreement on findings. So the GI effects on gastric motility, which are vagal mediated, are considered subject to tolerance in tachyphylaxis. However, one of the early studies done on this was done on GLP-1 infusions in healthy patients. Again, very, very different half-life of that drug. So those results might not necessarily be able to be extrapolated to patients on the long-acting commercially prepared drugs. Studies on RGC, residual gastric content, have been conducted at different durations of therapy with the different medications, with different ways of trying to assess the time to gastric emptying. One of these being the paracetamol absorption test, which is a suboptimal test that is indirect. And there's other ways researchers have tried to quantify time to gastric emptying. Van Zullen and colleagues, in a paper they wrote, speculated that tachyphylaxis to gastric emptying after 8 to 12 weeks may decrease the cause for concern, even writing in their paper that after 12 weeks, standard fasting times likely suffice, and that the delay was most notable for the first postprandial hours and early in treatment and became less significant later on. So after reading this article, found several responses in the literature, some letters about this with a lot of very strong opinions on call it a problematic concern of this statement that after 12 weeks we don't have to be worried anymore. So some other folks have also looked into this. So instead of the paracetamol absorption test, scintigraphy is considered to be more of a standard for measuring gastric emptying. And this study showed sustained delay in gastric emptying well beyond 12 weeks, showing that gastric emptying delay does continue long into treatment. In a response to the article I just referenced, these authors commented that the infusions of GLP-1 in healthy volunteers is not necessarily extrapolated to patients on the commercial drugs. they found that 56% of GLP-1 RA users had residual gastric contents compared to 19% control by ultrasound, and this was in a population of elective procedures. Interestingly, they found no significant association between increased RGC and the short or long-term duration of therapy. Said another way, that the duration of treatment did not matter, whether it's the first 4 to 8 weeks, whether it's been a year. So the tachyphylaxis, the gastric emptying, we're going in the direction of aspiration risk, and what is that risk and how do we reduce it? So as everyone in this room knows, aspiration risk is multifactorial. Depends on the patient, depends on the surgery, depends on when they last ate. This includes full stomach, lower esophageal sphincter tone, esophageal disease, or delayed gastric emptying from other causes. And then we have anesthetic factors, some of which could be light anesthesia, supraglottic airways, positive pressure ventilation, long duration of surgery. So digging in a little bit more to residual gastric contents and some of the researchers that have attempted to quantify this for us. A paper by Silvera and colleagues, they found a 5 times increased risk of RGC in patients taking semaglutide prior to EGD. And they were looking at EGD patients because you could be direct visualization of gastric contents if present. They found a 5% overall incidence of RGC in their control data compared to 24% in the semaglutide cohort, so that being the 5 times increase. And they compared that to, they referenced a large cohort of 85,000 patients that had found an overall 3%. So a little bit higher in their 5.7, but definitely a big jump up to the 24% in the patients on the GLP-1 agonists. They found that combined upper and lower endoscopy had a lower incidence, which is not surprising given the bowel prep and low residue diet leading up to a colonoscopy, which could also have implications. If you had a patient that had a bowel prep, you might treat that patient differently. And they theorized that the effect of GLP-1 agonist is likely dose dependent, which again might be different for your diabetic patients and your weight loss patients, with the weight loss patients generally receiving higher doses. Some very similar results. Kabori and colleagues found a 10 times increase in RGC in patients on semaglutide, 5.4% compared to 0.5. Stark and colleagues, a 4 times increase, 6.8 compared to 1.7. Sen and colleagues found a higher prevalence of RGC in users at 19% for elective procedures, independent of diagnosis of diabetes, meaning whether it was for weight loss. And they found this was elevated beyond 7 days with decreasing each day. So, the idea that stopping it for 1 week ahead of time may not be enough. I'm still finding RGC beyond these 7 days, but then seeing subsequent decrease every day after that. Wu and colleagues looked at patients undergoing EGD versus those who were starting GLP-1 agonists after the procedure. They wanted to try to get a little bit more similarity in the patients, meaning patients that were all indicated for GLP-1 treatment, but those that hadn't quite started yet. So they found RGC in 19% of the GLP-1 RA group, with overall 4 intubations intra-procedure, generally finding gross, full stomach upon placement of the endoscope, and then 1 witnessed aspiration. And then in their control group, they saw 5%. So again, method of measuring gastric emptying does play a role, whether that's ultrasound, direct visualization, scintigraphy, or paracetamol absorption test. This was a study done by Sherwin and colleagues in 2023. Sorry, I know the text is probably a little bit small. This was done at Mount Sinai. This was prospective. They looked at a semaglutide group versus control after a fast of 10 hours, and then underwent gastric POCUS in the supine and right lateral decubitus positions. And then they did a second scan 2 hours after 12 ounces of water. So this was only with 20 participants, so it was a relatively small study. But if you can read it, as you can see, in the semaglutide group, we're seeing 70%, 90% after being fasted after the 10 hours, depending on position. Across the board, all higher than in the control group. Interesting, the control group, not 0, still seeing 10%. Again, very small study. They recognize limitations of this, but significant differences. What we tend not to quantify is how many patients with no risk factors have gastric contents when presenting for surgery. It's one of those things we don't always think about because the patient's healthy, the patient's NPO, so it is interesting to see the numbers of the control group not being 0. But the big question is, does evidence of gastric content equal increased aspiration events for these patients? This is obviously something that's very difficult to study. We're not doing randomized control trials to see who aspirates and who doesn't, and we're using residual gastric contents as a surrogate for aspiration risk. So role of gastric ultrasound, also this could be a talk in and of itself, but anyone that's been trained in POCUS would be familiar with this. Definitely some benefits of gastric ultrasound. This is a quick, easy, once you've been trained, non-invasive procedure, of course, which can be helpful for not only the decision to cancel or proceed, but it might modify how you're going to treat this patient, assuming we are going to proceed. So maybe rather than assume full stomach, this patient might not require an RSI. On the flip side, even though we didn't suspect a full stomach, maybe this may change our plan to an endotracheal tube versus a deep sedation or a supraglottic airway. Consideration for reassessment after a pro-motility agent, if that may or may not help with your extubation planning. There are some limits here. 3 to 5% of scans can be inconclusive, but definitely a role for future study here in quantifying time to gastric emptying. So going back to the big ticket question, does residual gastric contents mean pulmonary aspiration? So aspiration overall does remain rare in our practice. Depending on what source you look at, you'll see different numbers, but overall a rare occurrence. And every regurgitation does not equal aspiration. Every aspiration does not mean prolonged mechanical ventilation. Every prolonged mechanical ventilation does not mean a fatality. But that doesn't mean we're not taking all the steps to reduce the risk of these events in the first place. Tough to have quality prospective studies. And going back to those control groups with the non-zero rates of residual gastric contents. In diabetic patients not taking semaglutide, identifying a gastric volume that's been considered significant at about 12%, but this is not significantly different than non-diabetic patients. Again, meaning that when you're looking, the rates of residual gastric contents in the so-called control patients are not zero. A paper by Dixit and colleagues found no higher risk of respiratory complications in patients on GLP-1s undergoing emergency surgery. So they wanted to let's look at the cases we have to do and try to see how many events there were, and they did not find a statistically significant difference. Again, doesn't mean that the risk isn't there, just means that they didn't see significant incidence of it. Case reports have been also very big in this realm. Again, with the difficulty of doing randomized control trials. So just a couple, quick ones for that. Pulmonary aspiration seen during upper endoscopy after 18 hours of fasting. Regurgitation in a 48-year-old female undergoing GA for elective breast surgery after 20 hours of solids fasting. And she did not have a history of diabetes or obesity. This was more elective weight loss and a BMI of 28. Another case report of aspiration during general anesthesia with an LMA for elective lithotripsy after 14 hours of fasting. This patient had emergent suction intubation. Patient did well, but did not report her semaglutide use because this was for aesthetic reasons. So another thing there, perception that an aesthetic medication being used for weight loss purposes may not be thought of by some patients as being important to report. Most people aren't telling us if they get Botox. Maybe they're thinking of it kind of along those lines. This author also did a retrospective analysis of 62 non-diabetic patients taking semaglutide and found that only 34% volunteered use of the drug, with the remainder needing to be prompted. And back to our vignette, with the availability of telemed prescriptions and not even having to go through someone's primary care doctor, these things may not show up in existing charts. They may not show up in the medical record, so it may take a high degree of vigilance to find out if patients are actually on these medications. I think I mentioned the 34% volunteered. Another case report of a patient, 60-year-old for an MRI, had been held for 7 days, fasted for 18 hours, and residual gastric contents found on POCUS. 50-year-old for a hysterectomy that stopped tirzepatide 2 days before surgery, large volume particulate emesis. So you can see where we're going with this. Lots of case reports of this existing, but then again, everything with a grain of salt. The case reports we're not seeing are the patients that had full stomachs but did not have a regurgitation event, did not have an aspiration event, or patients that we don't know about, again, with residual gastric contents that didn't end up having any event. So some of the challenges here, and we've touched on several of them. What is the impact in diabetics versus prescription for weight loss? Our diabetic patients do have a higher risk of pre-existing gastroparesis, of course, but then again, we're seeing higher doses of these agents in the patients for weight loss. So what's the impact there on their gastric emptying? Optimal timing for withholding, and we're going to dig into that a little bit more. Duration of therapy. What is the role of tachyphylaxis? What is the relationship between residual gastric contents and aspiration risks? And acknowledging that gastric ultrasound is helpful, but there are some limitations. So what can we do? So there are several proposals in the literature that the holding of 1 half-life is insufficient, and should that be extended? And if it needs to be extended, should a bridging therapy be employed? Is there a effective proposed increase in fasting time? And we already know that prolonged fasting itself is not beneficial. Just saying we'll be overly conservative and fast the patients for longer isn't very helpful, especially in the days when we're trying to have carbohydrate-rich preoperative drinks for patients. How do we mitigate the risk? Is RSI our best option? Is there a role for prokinetic drugs, which is largely unknown? What is the effectiveness for our prokinetic agents? Secured airway versus sedation, changing our anesthetic plan. Employing gastric ultrasound potentially, a patient-tailored approach, always very important. And of course, gastric decompression before emergence when we do have the concern. So like many other things in our practice, a major area for future and prospective study, and definitely shared decision-making with our patients and our surgical colleagues. So expanding on what can we do? The ASA offered us a little bit, and I'm sure most people have probably read this, released in June of 2023, consensus-based guidance on patients, both adults and pediatric patients, on the GLP-1 agonists. So just to summarize, for elective procedures, it's generally thought that patients that are on the oral agents, such as Rybelsus, stop 1 day prior to surgery, and patients that are on weekly dosing should be stopped a week prior to surgery. This recommendation is irrespective of the indication, whether it's for diabetes or weight loss, whatever the dose is, or the type of procedure surgery for elective cases. And the recommendation that if they need to be held for longer than this regimen, endocrinology should be involved for bridging diabetic patients. On the day of the procedure, if GI symptoms are present, such as nausea, vomiting, abdominal bloating, abdominal pain, consider delaying an elective procedure and discuss all the concerns with the patient and the surgeon. If the patient has no GI symptoms and it's been held for this period of time, proceed as usual. If the patient has no GI symptoms and has not been held for the advised period of time, what to do? And there's a few options there. Consider proceeding with full stomach precautions. Consider evaluating gastric volume by ultrasound if available and reasonable to do. If stomach is empty, proceed as usual. If stomach is full, either consider delaying the procedure or consider proceeding with full stomach precautions. And currently, there's no evidence to suggest the optimal duration of fasting. Should the 8 hours of fasting recommendations be extended? So I know, looking through this, we pulled this up a lot in the anesthesia workroom in the morning because we'll have people come in and ask, my patient took their Wegovy 4 days ago. What's our policy? We don't have a policy. We have the ASA recommendation, and a lot of our colleagues are looking for what is the answer. Well, the answer is not crystal clear. The answer is you, the patient, and the surgeon are going to make a decision together. Some of the notes put in by the ASA were that the gastric emptying effects are reduced with long-term use, likely due to tachyphylaxis. Again, that's not a hard and fast statement. That's something that's still an area of significant research. There is concern for pulmonary aspiration with general anesthesia or deep sedation. So if this were a regional technique or more of a conscious or moderate sedation, we may feel differently. The presence of GI symptoms is thought to be predictive of increased residual gastric contents. So they do make the specific mention of does the patient have any GI symptoms day of surgery. There is acknowledgement that the evidence for guidance is sparse. And then, of course, if you're dealing with an urgent, emergent case, proceeding with full stomach precautions. So what that basically looks like is this. And without going through the algorithm, I'm sure most people have seen this or something like it or have read through the ASA guidelines. And this is what most of us are doing on a daily basis when we encounter these patients. But this does make a lot of anesthesiologists a little uncomfortable because it's not a crystal clear answer, and we are very worried about putting our patients at risk. But this is currently one of those areas where there isn't enough yet to say black and white, here's what we should be doing. Refining NPO guidelines is something that comes up every few years, and it's yet to be seen exactly if and when and how this will be impacted. So the ASA did just put out 2023 updated fasting guidelines for a couple specific things. Things like carbohydrate drinks, chewing gum, did not address this in the formal guidelines beyond the consensus statement we just reviewed. But of note, we talked about the half-lives. So with a half-life of about a week, you're talking about 5 weeks to steady state for starting the drug and 5 weeks of termination of effects. So one author recommended holding the drug for 3 half-lives to allow for 88% clearance of the drug. And this would be relatively easy for weight loss. We would say the downside could be there could be some rebound weight gain possibly. For the diabetic patients, this is more problematic. 3 weeks, that's going to have impact on their glycemic control. So having an endocrine consult in this situation would be important. Is this necessarily easy to do? Is it the right thing to do? So we're not crystal clear that holding it for a greater number of half-lives would cause this risk to be significantly reduced, may have negative effects both on weight loss and on glycemic control. And one day we'll wait and see if there is future formal inclusion in the ASA guidelines after more research has been done. So, of course, what this comes down to is a patient-centered approach, and the only reason I put this slide up here is, as anesthesiologists, risk reduction, risk mitigation is an enormous part of what we do every day, and aspiration risk is only one of the risks that we seek to reduce. But aspiration risk is very multifaceted, so this slide just shows several reasons patients can be at risk for residual gastric contents, delayed gastric emptying, regurgitation, aspiration, and this therapy with GLP-1 agonism is one of them, but it's also a very popular one now. With the number of prescriptions absolutely exploding, we're going to be encountering this on a daily basis. So preoperative planning is paramount. This is shared decision making. The algorithm is helpful. The algorithm involves the patient and the surgeon. Employment of gastric POCUS may become more prevalent over time. An appropriate procedural location is, of course, very important. If you're going to be proceeding because the surgery needs to go and you do have concerns, you're going to want to have an anesthesia machine present, the ability to rapidly secure the airway if needed, if that's not the initial plan. And then, there's logistics, touching back on being overly conservative, saying the patient, what are we going to fast a patient, 24 hours, 48 hours? Obviously, that's not practical nor healthy. Delays in care is something we have to acknowledge, just telling the patient they can come back. The rapidly growing ovarian lesion is one thing that could be a malignancy we're dealing with, but even with the elective total knee arthroplasty, that patient may have already planned child care, pet care, their stay at rehab, and just to say you're going to come back in 2 weeks might not really be practical, not to mention, surgical cancellations, financial losses for the hospital. We have to be judicious in all of these aspects. And then just in red below, something I like to, teach all my residents and fellows is that guidelines are guidelines. These are, again, not on black and white. There's not always black and white answers. I do a lot of obstetric and regional anesthesia. The ASRA guidelines are not laws. They are, meant to be, adhered to as much as you can, but, especially in our obstetric patients, you're going to have to deviate from those sometimes to get that patient taken care of appropriately. And this is no different. So lingering questions. Is perioperative GLP-1 receptor agonism use associated with higher RGC? If yes, does this result in increased aspiration risk? If yes, what risk mitigation strategies can be employed? How long should the drug be interrupted preoperatively given its half-life? What is an ideal and practical fasting time? And what will the role of gastric POCUS and pro-motility agents be going forward? So I feel like we maybe leaving with just as many questions as we started with, but this is definitely something that needs to be a conversation amongst us and our specialty, with our surgeons, with our patients, and definitely going to be an area for ongoing research in coming months and years. And these are all my references, and thank you so much for being here.
All right. Thank you so much, Dr. Wenzel, for that excellent presentation. Our next speaker is Dr. Reggie Fuller. Dr. Reggie Fuller is originally from the Pacific Northwest, but moved to Arizona for medical school. He then attended the University of Nebraska for anesthesia residency, stayed for a fellowship in pain medicine. After the fellowship, he stayed on at the university as staff. He will be speaking on pre- and post-operative outcomes for the chronic pain patient. Please join me in welcoming Dr. Fuller.
Hey everyone, thank you for having me. I'm incredibly humbled to be able to stand here and talk to you guys about the chronic pain patient and some of the more minimally invasive procedures that are going to involve more of the OR realm and not just our day-to-day kind of peri-procedural suites. And we actually do these in the GI suite. 99% of what we do not require an anesthesiologist, but of the things that we do, I'm sure that these are probably novel, not only just to the pain field, but also to the anesthesia providers. You guys come in and say, okay, what is this procedure? What am I supposed to do? So no disclosures. There are a couple of industry devices that fill a niche for a very specific treatment. So I will name them by name just because unlike a dorsal column stimulator, something like mild, that's the only one that is filling that space right now. So objectives, just want to define chronic pain, and then highlight just kind of relevant anatomy and what leads to someone developing chronic pain, not necessarily post-surgical pain, but as maybe a chronic pain patient who has diabetic peripheral neuropathy, who's coming in to undergo treatment for a back fusion or even some small orthopedic procedure. They're still going to be on similar medications as someone who is having maybe a lot of post-surgical back pain, who's getting another type of procedure. Again, risk factors associated with developing chronic post-surgical pain, different medications, and different actually patient-specific qualities that may have made them more prone to develop chronic pain. Dr. Bartles kind of touched on that, and I really like what he said at the end. I was talking, I'll kind of touch on it a little bit more. But, and then this is where some of these common and novel interventional therapies and the different options for anesthetic management. So pain in a nutshell, chronic pain in a nutshell is usually this after this 12-week mark. But really, it's more of this, basically you're having pain that is not providing a physiologic basis anymore. It's not telling you to take your hand off the stove, or you have a wound, you need to be off your foot for a little bit. This is ongoing pain that is smoldering both in the periphery, but also in the spinal cord itself. And so I often tell my patients, I realize your knee hurts, but chronic pain doesn't just live in your knee, it also lives in your spine, and that's why we have all these different treatment modalities for it. So going from acute to chronic, and so you can divide different types of pain, both neuropathic, nociceptive. There's also an inflammatory component. I didn't really delve into that one, but either way, these all converge in the same way to develop pain that we will define as chronic, as ongoing. Usually this is a damage to some sort of peripheral nociceptor that is overwhelming the system being in the spinal cord, who's then going to transmit those pain signals up to the brain. And there's going to be a series of events that are going to kind of cascade a snowball into what's going to develop a situation where you've kind of maintained the propagation of these pain patterns. And this occurs in both a peripheral and a central sensitization type pathway. And so with the peripheral sensitization, basically there is a lot of ectopic activity, likely from a number of receptors, but predominantly the sodium channels are the big offenders here. They're going to be constantly sending signals into the system. And then within the system, there's going to be basically a way to upregulate and maintain those pathways. Initially, this is something that is protective. You're running from the tiger, you broke your ankle. All right, you shouldn't be walking on your ankle to cause further damage. However, at a certain point, 3 months, 12 months, 12 years down the road, you do not need to be still feeling that pain from that ankle. And so it's this system that is being overwhelmed. I kind of think about it. I was watching my 3-year-old nephew a couple weeks ago, and they just had dinner and they were going to go out. And my sister-in-law was like, he can have one piece of candy from this jar of candy on the counter that he basically worships, no more. And so it was, okay, here's your candy. I'm the cool uncle. Maybe you can have one more. And then, can I have another? No. Why? Your mom said no. Why? And so why? About the 10th why, it was, okay, here's your jar of candy. And so I am, I am now, basically, he is this damaged peripheral sensitization of where he's sending me all these signals, and I am this, thought cool, but now worn out uncle in the brain. I'm just, whatever. And so that's kind of how I conceptualize this. Yeah, and you're probably thinking, like, they let that guy talk to patients, but so that's kind of how I think about it in a nutshell. And so what we're doing is the sustained signaling from these primary afferents are coming in, and these changes are happening both in the brain and the spinal cord, and specifically in these lamina and the dorsal columns. And so what normally should be occurring, again, where we want to provide something that's protective, where, okay, our ankle's hurt, we just need to walk on it until it heals. We have this descending inhibitory pain pathway, and this actually starts in the periaqueductal gray with projections into the RVM, or the rostroventral medulla. And this is a dial that we can turn down pain, basically trying to come up from the periphery that we would interpret as pain. And a lot of this pathway actually involves serotonin, norepinephrine, which is important. Later on when I touch on some of these medications, but also has the A2 delta calcium channel involved as well. Things that upregulate or try to maintain the system to go up towards the brain and maintain pain is these NMDA receptors, which we've touched about on ketamine earlier. And so with chronic pain, you actually have more signals coming in. You have a lot of ectopic activity. These nerves are firing and constantly sending signals in, and then you have dysregulation of this descending inhibitory pain pathway, and so you're not really getting a lot of basically counter balance to try to calm down some of this. And then more specifically where this is occurring is in this dorsal column. And so here I'm showing the different types of pain fibers. So we have our C fibers, A delta and A beta. And so usually I tell people, okay, you have your C fiber. This is the slow burning pain. So you heat up the cup of soup in the microwave. You grab it. You don't know that it's hot until you can drop out over the floor. And now you're cleaning up a mess and you're hungry, and it's terrible. A beta fibers usually this kind of like a dull, a little bit more localized, but not quite, a sharp pain. And then A beta is this kind of light touch, or more of a mechanical stimulus. These A beta fibers actually send projections up to the periaqueductal gray to then activate the descending inhibitory pain pathway. And they also have local activity that is going to try to basically stop or inhibit a lot of the channels that are firing from these C fibers and these A delta fibers. So if anyone's played baseball or softball and has been hit by a pitch, the first thing you do is you start rubbing it kind of instinctively. And then on the other side here, what's showing is basically this green and this blue nerve is what's coming from the periphery, and then what's going to synapsing up to the spinal cord. But then you have these other neurons that are going to either propagate this signal or try to basically calm it down or stop some of this firing. And again, that's coming from the descending inhibitory pain pathway. And then more specifically, where these nociceptors are landing in the backside of the spine is our lamina. And so within the lamina, most of the C fibers and some of the A delta fibers, again, the slow burning pain or the sharp pain, are going to part kind of in this backside, this lamina 1 and 2, where the A delta fibers are going to be predominantly in these deeper lamina. Again, these A beta fibers are going to project actually into some of the more superficial lamina, and that is how they are able to inhibit some of this pain. When this system is overwhelmed and you're developing more of a chronic pain type scenario, you actually have sprouting across the lamina. And so this is where you can wind up with something like allodynia. So you have a patient who has severe neuropathy or something like chronic or complex regional pain syndrome. And one thing I always ask those patients are, okay, if you're in bed and you pull the sheets like across your foot, and they're like, oh my God, I can't have a fan in the room. And that's because there's sprouting of these receptors across this lamina. And then what's happening is that the incorrect information from the periphery is getting in this lamina, and then it's getting thrown up to the brain to be perceived. But that pathway that's coming up is the incorrect one because of the sprouting across these lamina, which is inappropriate. All right, so this is kind of from a basic science standpoint of what's going on at the actual kind of spinal cord itself, more or less diluted down. And so our patients then that are coming here, they have several risk factors that are going to predispose them to either being difficult to manage from an anesthetic standpoint, and also, and again, I really like that Dr. Bartels touched on this, but from a neuropsychiatric standpoint, and that there are people who develop chronic pain, and there are people who don't with very similar injuries, and some of this has to do with how they perceive their pain. And so one thing too is an underreporting of medications. I know that was touched on earlier about who's actually saying which GLP-1 or agonist that they're taking. I had a patient, gosh, this was maybe Thursday, who had wanted to be on the max dose of gabapentin, and then went home and looked it up, and after they were put on the 3,600 a day, misinterpreted that as 3,600 online, had misinterpreted that then as 3,600 3 times a day. And so people are taking too many medications, not taking enough medications, also who are probably taking opiates from a friend or a family, or I guess if you're nervous enough on an airplane, someone right next to you giving you Klonopin. So we're probably not going to report that. That is wild. But anyways, and then this overestimating the effects of a painful stimuli. I think this ties into this poor pain coping strategies. These patients have a thing called catastrophizing. So this pain is going to be terrible. No matter what we're going to do, it's not going to help. I'm going to run into issue. I'm going to have to be hospitalized again. I'm going to have to stay in the hospital a long time and they wind up in this cycle. And again, I think this is where like a pain psychologist can play an incredible role in helping us kind of reduce those feelings of anxiety. I strong believer in patients who just are anxious prior to procedure. For instance, a lumbar medial branch radiofrequency ablation requires 2 diagnostic blocks. These are done through 22 gauge spinal needles, so not very big needles. More often than not, someone is the first block. It was kind of rough for them. They had a lot of pain. They were sore afterwards. The second block, they're like, actually, that was pretty easy. And I think because they knew what to expect, and they knew that these needles are small. And I was telling them like the worst part's the numbing medication. It's just like you're at the dentist. It's a pinch and burn. Like everybody hates going to the dentist, but you kind of make it through. My wife, who's a dentist, she hates when I tell patients that. But it's true. I think people then they get used to this will be okay. Significant reduction in anxiety and pain just to the procedure themselves. Even with the lidocaine on patients I offer Xanax to. And then again, tolerance to opiate therapy. There's some studies that show that like IV morphine and epidural infusions may increase postoperatively 400% compared to a patient who's fairly opiate naive. Some of the other medications that we prescribe, again, there's been a big push to use a lot of non-opiate type medications. From one of Dr. Bartels' slides, when it looked at number needed to treat, one of the TCAs, nortriptyline, is used quite a bit. It has one of the lowest number needed to treat for patients with neuropathic type pain. Unfortunately, we don't get to use it a lot. I worry about, so this is actually an AI generated picture, but so say this gentleman here, I want to place him on nortriptyline. Well, maybe he's on a blood thinner, his prostate's the size of a grapefruit, he's getting up 4 times a night, he's going to stand up, get hypotensive, and he's going to fall and hit his head. So I don't want to put him on a medication like a TCA, so then I'm leaning more on like a gabapentinoid or something like that. The recommendations actually for TCAs are to continue them through the perioperative period. The data was kind of wishy-washy on tachyarrhythmias outside of overdoses on TCAs that were actually consequential, that required potentially a cardioversion or basically an inpatient stay. And then a lot of the gabapentin we kind of touched on. This is different than what Dr. Bartels was indicating with more of acute pain requiring gabapentin. A lot of these patients, especially once they come from my clinic, are on some sort of either gabapentin, an SNRI such as Cymbalta, or pregabalin, especially going into surgeries. There is some data to suggest that patients being on these types of medications prior to a big lumbar fusion or a cervical fusion have a less likelihood of developing chronic pain. This isn't, again, I'm not in the acute pain realm, and that's not what I'm focusing on with these patients. I'm trying to keep them maintained on a dose kind of out, and then, not always coming back to the clinic because they're having uncontrolled postoperative pain. Using a lot of oral ketamine too in some of these patients. Again, trying to mitigate the side effects of usually the hallucinations or just feeling very uncomfortable with their dreams or thoughts tends to be the big side effect. Another one that we use is naltrexone. It is outside of the 3 FDA-approved medications for fibromyalgia. Naltrexone's used off-label with fairly mixed data on it. That usually we recommend discontinuing 48 or more likely 72 hours prior to a surgery. And any patient I have on naltrexone, I tell them that if you're planning a surgery, here's the plan. Call me, let me know, we'll lay this out, but have you off of it for about 3 days but before you undergo a surgery, because you are going to need some sort of analgesia. Okay, so we've kind of talked about how we've developed chronic pain, some of our chronic pain patients, and then now here's some of the more pain-specific devices and procedures. And so this is the one I get most texts from my friends who are still in anesthesia, in anesthesia only, who are doing cases and go, hey, I got a patient with a spinal cord stimulator. What do I do? I had a call about 3 or 4 weeks ago. They were doing a kidney transplant. They'd found out the patient had a spinal cord stimulator. It was on. They had no idea where their controller was, and they needed to go. This organ was going to be actually given to the patient. They couldn't reschedule it. And so things that basic considerations with specifically dorsal column stimulation is trying to avoid the device. Think of this kind of like a cardiac device. You're not going to advocate that a grounding pad gets put over. You want it on the contralateral side, as far away as it can be. Another big question, I guess, all right, I have a patient with a SCS, can I get an MRI? And the answer is yes. So each manufacturer is different. Most of these devices are MRI conditional, so they'll go into like 1.5 Tesla. It also depends on where the leads are at. But there are some right now on the market that are advertising full conditionality up to 3 Tesla. And so usually these will have to be put into an MRI conditional mode. So this will also require that the device be on and working and the battery actually can be turned on. And so for them to safely undergo an MRI. Other things too are basically, you have a patient with a spinal cord stimulator and maybe they're coming in for a total knee replacement, or recently we had one, a obstetric patient, and you want to perform neuraxial anesthesia for them. This can be done safely. Usually you will need a chest x-ray. Hopefully on your obstetric patient, that is one that you can at least pull up and not have to make the decision to get one or not. But most of these are actually placed fairly high in the spinal column. For most back and leg pain, we are using contacts to cover the T9-10 interspace, so it should be well out of the lumbar area. For pain physicians such as myself, I usually put these in percutaneously, and so we'll enter the space around T12L1. Sometimes, given hardware or spinal stenosis, we're required either to go lower or higher. I do try to go higher, but nevertheless, these may enter in as low as T2. And if imagine if you have a patient where maybe their anatomy is not as discerning as you want it to be, it would be nice to have a chest X-ray to pull this up to figure out where these leads are at. So not only are these leads entering in, say, at T12L1, but there's also an anchor site that's usually a bit lower, and then these leads are tunneled. Theoretically, the tunneled leads should not be in your pathway. But again, it would not be wise to intentionally contact these with an epidural, like a TUI needle. And so planning around on how you can access that epidural space with a patient with a known device. Usually the IPGs are placed off to the hip, so they're kind of over the ilium. Some of these are placed actually right next to the anchor site, so they may be in the thoracolumbar junction and completely out of your way, and you won't have to worry about it. And others are actually placed on the abdomen. More commonly, though, they look like this picture. And you can also tell whether or not they were percutaneous leads or are they paddle leads. And so this is actually a paddle lead. This is something that would be incredibly easy just to take 2 seconds to Google. And no, a paddle lead requires a laminectomy, and these will usually have more of the system out of your way, and we won't be having these leads that are trailing. And so one thing you can do is actually use an ultrasound. So if you're unsure of where these leads are at, you see that this patient has they have a spinal cord stimulator. You're maybe not as confident on where to place the spinal further, or maybe they're a difficult spinal and you're kind of moving up and down the lumbar space, and you're like, I really don't want to, hit these leads. This has been one recommendation was using an ultrasound to identify these interlaminar spaces, and then coming all the way down to kind of L5 in the sacrum, and that kind of being your starting spot there. Until then, you can potentially visualize these leads, or if you find an opno, this is these coudes, or basically the type of epidural needle we use. We're entering at the 12-1 space, and so you can kind of count and make sure that you're well aware from contacting any of the system. I know this is kind of a busy slide, but just things I wanted to touch on are basically like what you can utilize. If a patient needs a therapy and they have one of these systems in place. And so usually, like I said, the big one is usually an MRI. Most of these are MRI compatible. And they just need to be on and placed in an MRI compatible mode. And then with electrocautery, turning the device off, placing the grounding pad as far away from the IPG itself, and then advocating for bipolar cautery. I thought it was interesting on this one. They also had, I think, a defibrillator, and they talk about should lethal arrhythmias occur, place paddles away. I would think that anyone in that situation, you're not really going to worry about if someone has a spinal cord stimulator, just going to shock them. Okay, so another one, a big thing that comes up in our realm is lumbar spinal stenosis. And so this is basically degenerative disc disease that has resulted in narrowing of mostly, and what I'm going to talk about is the central canal, but you can have neuroforaminal stenosis, lateral recess stenosis, and neuroforaminal stenosis. The lateral recess stenosis and neuroforaminal stenosis typically result in a radiculopathy and is not treated by this device that I'm going to talk about. But it's a pretty prevalent issue, and it makes up 90% of my practice is dealing with spinal stenosis in one way or another. And so what we will be targeting here is what's shown in D, C being this lateral recess, B being this foraminal, and A being this extraforaminal zone. Our typical lumbar spinal stenosis patient is this older gentleman or woman who every time they go to the store, they grab the shopping cart and they lean over it. They're actually increasing the cross-sectional area of their spinal canal, and that's kind of giving them a little bit more room to breathe, because if they don't, they can walk maybe a block or two, or even half a block, and they get this achy sensation in their legs, and they feel like they're walking through water. They sit and they rest pretty good. I don't know if anyone follows college football, but because I'm not from Omaha, usually the next slide would be a Huskers helmet falling over the gentleman with all these national titles from the early 90s that every single person in Omaha has been carrying around with them for the last 20 years. So I use to my advantage. That's usually when I go to Costco or something. For treatment of central canal stenosis with associated neurogenic claudication, typically it would start with physical therapy, and then we would do an epidural steroid injection or an ESI, and there was this treatment gap until we went to a laminectomy and a laminectomy infusion. And mild kind of fit this niche, and mild being the minimally invasive lumbar decompression, of being able to bridge patients through that gap. Patients who wanted to do everything but surgery, patients who couldn't get surgery, or patients who are like, I would be willing to get surgery, but I want to make sure that everything's been exhausted prior to proceeding. And so what we're actually doing is debulking the ligamentum flavum at these stenotic levels. And so here showing the narrowed ligamentum flavum causing central canal stenosis. This MRI on the right, where these arrows are elongating, is actually measuring it. So as long as we're over 2.5 millimeters, we can debulk this ligament. And this is done all percutaneously, and it's all fluoroscopically guided. And so it's through these ports. And the manufacturer, their big thing is this is basically leaves like an aspirin size hole in your back, and we just glue it up. There's no sutures or anything like that. The anesthetic management on this can vary from anywhere from a general to local only. I have a patient on the books right now who is basically a pulmonary cripple, has terrible COPD, multi-level central canal narrowing. No one is willing to. He's been to our pre-surgical anesthesia screening clinic twice and was told that he's not an appropriate candidate for surgery. And so this is something that I had offered him, with a caveat being you're going to get lidocaine, bupivacaine, and someone tapping you on the shoulder saying it's okay. And actually, people do really well with this. I'm kind of surprised that we're actually able to scrape bone, part of the lamina, both above and below this treated segment and the ligament flavum, and they do really well. I originally found out we could do this under straight local. A patient drove 6 hours through outpatient surgery center, and while he was checking in, was eating Wendy's. So I had the conversation was, okay, I can do this, but and he would have been he was the prime candidate. He was very kind of tough farmer, Midwest, salt of the earth guy, and he did great. Some people want a full general for this. Other people would more prefer a kind of more of a MAC, or even just like a little bit of Versed, a little bit of Fent, because once these people wake up, they can go home. There's not a lot of post-op recovery involved. And the same can be said with like a dorsal column stimulator, spinal cord stimulator. Some of my colleagues will do full generals with motor evoke and sensory monitoring. I do a MAC only after I get the leads ran. So I'm trying to prevent a neuritis because I don't want to be banging up against a lead or a nerve root without the patient being able to tell me. And then once I am ready for basic incision to create the anchors, create the pocket, apply the anchors, create the pocket, and tunnel the leads, then usually it's, all right, I'll see you in an hour. So another therapy is for basovertebral nerve ablation for vertebrogenic pain. These are patients who usually I have just focal back pain. I can't really lean forward. I don't like to do anything with anterior column loading. Bouncing in a car. I've had at least 2 patients who've told me they bought different cars with different suspensions because of how bad the roads are in Omaha, but also how bad just bouncing force can cause pain. These are typically done under general anesthetic. This is the approach is very similar to a kyphoplasty, in that a trocar is inserted through the pedicle, and we actually ablate the basovertebral nerve in this area, with the thought being that if there's no nerve there to basically sense any of that compressive force, then they should lose a lot of that pain. This is a pretty successful procedure based on the industry-sponsored literature. This is not something we do at my hospital, more of a red tape thing. But this is typically carried out under general anesthesia using full neuraxial ASA type anticoagulation guidelines. So. As far as like a percutaneous kyphoplasty or cement augmentation, this is usually done for compression fractures. One of my colleagues, she does these solely under general anesthesia. I have a friend who does these at his ASC with 2 of Versed and 50 of Fent. There was a study that looked at basically using different types of adjuncts for anesthesia, and they found that using dexmedetomidine infusion, so a bolus and then an infusion, actually had very similar pain scores and less post-operative complications and decreased admission time for these patients. They did say that that group did have higher levels of bradycardia and hypotension, which we probably assumed just given the drug. And then I thought this was really interesting. This group actually looked at using a erector spinae block versus a general for a percutaneous kyphoplasty. And they specifically studied ASA 3 and 4 patients. So if you think of the patients who are going to sustain a compression fracture, it's usually my frail little old lady who's osteoporotic, and she gets a compression fracture, and then she's managed non-operatively, she has ongoing compression, and I do worry about them in the anesthetic periods because they are a higher ASA. And this showed that they were actually able to do this with they had very similar IV medication administration. However, most of this is done through an erector spinae block, which I know that was touched on earlier in one of the earlier talks, and I think it's a pretty cool thing that we can utilize. So. All right, it's my references. Thank you.
Thank you so much, Dr. Fuller. We'll now begin the Q&A portion of the lecture. If you have a question for Drs. Lobaugh, Wenzel, or Fuller, please come up to one of the floor microphones to pose your question. I'll start with an observation. I do 100% cancer, so I understand a situation where you may have a tumor progression. It's a big deal to cancel a surgery. They all have cancer. So what our institution has done is we have 7 days on injectable, and we do 3 days on oral, not 1 day. So that's just what our department has done, and we'll probably modify it down the road. Do you think the guidelines are going to get updated soon, like possibly at the meeting next month?
Honestly, I have no idea to expect when it would be. I feel like we're going to be going on loose on, kind of the existing guidelines for a little while and just using a fair degree of judgment and just patient-centered, patient-tailored approach on the individual case, which is one thing that's a little frustrating, is like I mentioned before, is, especially with a lot of my colleagues, some people I find are, great at having those conversations with the patient, and some people are they just throw up the medical legals, like, we have to delay this. I was like, what do you mean you have to delay this? Did you talk to the patient? Like, the decision was already made before evaluation of anything else, because some people feel like unless they're told whatever is in a black and white guideline, it's tough for some people to have those conversations, I think.
Yeah, and then also I jotted down a question for Dr. Lobaugh, and my question is, we are considering getting labeling machines. Are you in favor of that?
I think labeling machines are probably the minimum at this point in safety for medication in the OR. I think that the days of writing your preparation on a sticker and sticking it on a label is the risk is too high. Barcoding, scanning would be the next step. However, a lot of people I hear, again, I was at APSF last week, so this was a big discussion. Many institutions say, well, they can't afford barcode scanning. But I would say, if you go to the floor at every hospital out there, the audience, you probably have barcode scanning on the floor. So why can you afford something on the wards that you can't afford in the OR? And again, there are no safety checks as an anesthesiologist besides you. And if you're lucky enough to be in a practice where you have a team approach, maybe you could say that's your safety check. But for many people now, with staffing shortages, you are by yourself. And my institution, 70% of our cases are solo. So if you are not labeling or not color coding, the chance for you grabbing swapping syringes is very high.
It always impressed me, first day of residency back in the 90s, that we were handwriting this stuff in the OR, and a lot of us are still doing it. What impressed me is how we don't have more errors that take place all the time.
So Karen Nanji is in Boston, and she did a prospective study and said that 1 in 20
3 medications has an error, and 1 in every other anesthetic has an error. So I think that the problem is that medication errors are largely due to reporting, and the variance of reporting can be very significant. You could call too much, giving a bolus of propofol that's too much, and hypotension, is that an error? Well, in anesthesia, we can cover up a lot of our errors because we have the tool set that other areas or fields can't cover up. I think so. It's all about reporting, and until you create a safety culture where people feel comfortable reporting, you're never going to know the true incidence of that error.
It's very true. And then I had one other question. You may not know the answer to this. That word cloud that you displayed about where collaboration is in the middle. I noticed off to the right in small letters was PB&J. What is that about?
I would assume someone felt like that is their description of a partnership between anesthesia and pharmacy. And I think that for many people, having a relationship with pharmacy is essential, and you may or may not have that. But if you lean into a partnership, you will find that you can have a lot of opportunities for improvement through that relationship, whether it's you have a problem and you know who to call, or you're lucky enough at my institution, we are utilizing our pharmacy partners to build dashboards. So Epic is a challenge. Electronic health records are challenging, and getting data is a challenge. But our pharmacy team and the technology team has access to information that I could only dream of. So for me, I've been at Texas Children's for 8 years, and I've dreamed of a PACU dashboard that gives basic knowledge of clinical variation, post-op nausea, vomiting scores, pain scores, morphine equivalents, and pharmacy can build it because they have that information. Where if I tried to do that through my department or through a front door ticket in Epic, it would take me years.
That's so true. There's a lot of barriers, I think, in all the institutions we work in. I also had one question for Dr. Fuller. Is there so many different pain organizations and societies? Who should we look to for guidance on devices that are in patients, or turning them on, turning them off, things not to do with the patient, patient positioning, medications? Is there any one authority you recommend over the others?
So, are you guys able to hear me? Typically, we fall into ASRA, and ASRA has a pain society. Most of the devices, though, our recommendation, whether it's a pump, a DRG, a dorsal column stimulator, or a peripheral nerve stimulator device, because as you alluded to, there's a lot out there. It's kind of an exploding field, especially with neuromodulation, is to reach out to the representatives themselves, and usually the patients have a contact for that, and things change. Just recently, I had a patient who I had done a cervical RFA on about 9 months ago, and then she had a DBS at that time, got a new battery. And and at that time, we just turned the DBS off, and I reached out back to the rep and said, hey, is this the same thing going forward? And they said, no. We now believe that there's an increased risk of damage to brain tissue, and so we have to change our plan. And so because even, and this happened to be a Medtronic device, but I think there's other DBSs on the system, or ones that I don't know about. So my recommendation, what I've been practicing, is go to the source and find out what their actual recommendations are.
Very good to know. Do we have any other questions? Yes, Dr.
This is for Dr. Lobaugh. In the era of ongoing drug shortages and supply chain issues, do you have any practice recommendations for when we're dealing with vials of different concentrations, different colors, not having standardized medications available that can lead to drug error?
So I think that the problem is every hospital has a different set of resources. And again, this was one of the think groups for the medication error group at APSF, is the things that I could give you that I'm working on at Texas Children's, you might not have resources at your own institution. In fact, one of the people in that think group was like, we're still on paper at my institution. I still pick up a cart from pharmacy. And so it's really hard because hospitals are so varied in what they have access to. I would say high level, like pie in the sky dream for me in shortages is make your own drugs. I think we learned this in the hurricane that hit Puerto Rico when it knocked out the IV plant that made the IVs, and then we're like reduced to, is there really only one place that makes this? And so if your institution has the resources to make your drugs, you can use things much more efficiently. So we are leaning into robots preparing our drugs like Precedex, Propofol, Tylenol, because we see that the waste is much lower if we're using our own aliquots, because PEDS is a different world, right? But for other institutions that don't have those, I think that it goes into leaning into that relationship with pharmacy. And this is a constant conversation with pharmacy. I mean, we've had a shortage of ketamine, we've had shortages of sufentanil, shortages of some of the antibiotics. And I think that it's a constantly evolving game, and you have to really have that conversation and build in the safety nets or the backup plans. And you can't do that unless you know what's coming. And most anesthesiologists, I don't think, are looking up the, and I forget the website where the pharmacies list what they're expecting in shortage. So I've found that having that monthly or even maybe shorter than that, conversation with someone in contact. I personally get an email from our inventory person that says, hey, Lauren, this is coming down the pipe. Maybe we need to have that conversation, because you might be able to have different plans. Now, if we run out of propofol or you run out of bupivacaine, I think we're going to have to go to very different types of techniques. But I think that in summary, it just depends on what your resources are at your institution and how you're going to fight that. But I think that shortages are not going away.
All right, any other questions? Oh, yes.
This is regarding spinal cord stimulators and epidural placement for labor. I can see where a spinal is a reasonable thing if we know where it is and we avoid hitting it. But when you put an epidural in and say the spinal cord stimulator goes down as low as L2, I'm really concerned about the catheter getting tangled in that, because the catheter is going to thread kind of where it wants to. And I'm also concerned because with the spinal cord stimulator that you described, you do disrupt the epidural space. Are you going to have a block that's not going to be real reliable either?
Yeah, so really good question. And this, the data on using neuraxial procedures with spinal cord stimulators is fairly limited to case reports, and basically like, yes, we could do this. The one time that this came up as a consult, we had recommended basically threading the catheter in is what they felt was the least amount is comfortable. I would say that catheter migration, when we're threading those catheters, is fairly unpredictable. I mean, like, we wind up with kind of one-sided blocks. There's some case reports showing that they're in an epidural catheter all the way down, like a nerve root. And it becomes very apparent in the fluoroscopy suite when I'm trying to run these leads. I do think back, I'm like, God, how did I ever get an epidural catheter that went straight up, just because this is taking quite a while. And so that would be my recommendation. Usually all of our instrumentation as far as the anchors are going to be placed on the supraspinous ligament. This should not preclude the flow of medication through the epidural space, and definitely should not preclude anything through the intrathecal space should you need a spinal. There are patients who have both dorsal column stimulators and pain pumps. Basically, I think that the recommendation from what came out of our group recently regarding this was place the epidural catheter at the lowest point possible, and you, at that point, should not be threading all the way up into the thoracic space just with normal practice, and then just give yourself, because even then, if you contact with the catheter tip is so soft, I don't expect it to actually be disrupting the device that's in place. More of what we're worried about is damage to the leads with the TUI. And so my recommendation would be to perform the procedure as you would otherwise, especially given that the epidural space is fairly circumferential, and you should be able to get medication in that space. I'm not aware, but I can see where the concern of, like, all right, am I going to get this epidural catheter actually stuck in the actual lead itself? And again, that would go back to putting this as low, entering in with your TUI as low as possible, and threading it as little as possible. Most of these actual stems, again, are usually about T12L1 or higher. The paddle leads are just directly placed on the back of the dura, and so there shouldn't be much to tangle in that. And they're usually up at the 9-10 interspace for low back and leg pain. And I would imagine you're not planning a catheter that high. Hopefully that answers your question.
All right, any other questions?
This message is for Lobo. As an attending anesthesiologist working with pediatric patients, you had given a picture of the Swiss cheese model on there where things can go wrong that really aren't expected. And frequently, we find ourselves supervising various levels of residents that are also in training, or nurse anesthetist students, or a number of nurse anesthetists maybe in different rooms. Other than at maybe the timeout and mentioning specific medications to avoid, how do you allow them to have autonomy and not provide medications maybe that aren't indicated in certain procedures when they shouldn't be given, when maybe narcotics are important to withhold, or other medications that might interfere with staging of cancer or things like that? Do you have any guidelines that you might recommend?
I think that's the biggest challenge of teaching trainees in pediatrics, because there is a huge difference, and particularly at Texas Children's, we get residents after they've had at least 1 year of adult experience, and somehow that's going to condition them so that they're going to know how to take care of peds. But peds is not the adult world. And I think that frequently one of our biggest errors that come out of trainees is the dosage. They don't know the correct dose, and they make wrong assumptions in that. I think that the probably least helpful thing to tell you, which is the most available, is to have a very, very clear communication plan from the very beginning. I personally now go through each dose, especially with the newer trainees at the beginning of the month, and talk about what the dose per kilogram is, and then what the total dose should be for those, and try to be, I think they call me a little bit of a helicopter mom at first. And I think that that's essential. But I will caveat that some medication errors, at least I did a paper with Wake Up Safe and what's reported to that database. It's not just trainees. Attending anesthesiologists are making these errors just as much. Last year, I made a significant error in a dark room in a bronchoscopy with a kid that was bronchospasming, trying to get Decadron out of an open matrix drawer, and the Decadron is right next to the Toradol, and they're both brown vials, and one of them has a green top and one of them has a blue top, and I grabbed the green top instead of the blue top, so I gave Toradol instead of Decadron, and I made that error. My CRNA did not. I think again, I can tell you, high resource pie in the sky, I think that we should build clinical decision support, that when you swipe that drug, it gives you the dose based on the dose per kilogram as reference for those. The biggest error that we see is Tylenol dosages. Somehow residents, trainees can't quite get that it's either 10 milligrams per kilogram or 15. And if you're going to give high set in the PACU, you can't give 15. And so I think that the easy answer is to tell you communication, helicopter parent style communication. But really, I think the ultimate answer is we need better clinical decision support tools giving that reference point. We've built it into our EPIC so that we give general guidelines of doses that but it also is culture, right? I practice how I was trained, how my attending was trained, and it's to give the medication and document after. And so many of us do that. And you will not catch that error if you document after. You have to do the swiping, you have to do the barcode, you have to do that reference point to catch those errors before you administer.
All right. Well, thank you everyone for your questions. We're at time. We need to conclude the session. Please join me in thanking Drs. Lobaugh, Wenzel, and Fuller. You'll be asked to provide your feedback on the session when completing the attestation form at the end of the convention. Please remember the president's reception has been moved indoors, and it's right in the foyer out there, and it's beginning in just a few minutes. And there is the Atomic Habits Book Club in the morning at 7 a.m. We had a good time last year if you want to join.